I guess not. So, okay. So I think, are we all set up? Do we have everything? We had a couple AV problems, so I apologize. So I think at this point, I'm ready to get started and introduce our speaker, Dr. Eugene Orientale. Dr. Orientale was on the faculty at the University of Connecticut School of Medicine, correct? His specialties are geriatrics and family practice. And we've got kind of an interesting program today with a number of different topics. So I'm going to turn the program over to him now and let him, explain all of that. Welcome, Gene. So, thank you. And welcome, everyone.
Good morning and welcome. And thank you, Charlene, for the invitation to speak and also for the liberty to kind of put together a program that I thought would appeal to this very diverse group of practitioners. And you kind of go, well, how's he going to weave this together? But so we're going to start out talking about cognitive medical errors. Those are not we live in the world of medicine where errors are commonplace, but let's put to the side medication errors and surgical errors, wrong surgical site errors. And let's talk about errors that we commit in our minds. And so this is a grand rounds I gave, I think 5 years ago. And I think you'll find it very interesting. So we're going to talk about our biases and cognitive ills, and if you will, cognitive pills for cognitive ills. The second talk is one of those talks that I put together originally for medical students. And then I did it for residents, and then I did it for faculty. And it's sort of one of these, could you just give me the punchline kind of talks, or can you give me the epilogue? I don't want to read the whole book. And it's a talk about my career, the lessons that I've learned that I really wanted to share with learners. And now I'm sharing it with faculty and with practitioners like yourself. So it's going to be kind of an interesting, reflective talk on life's journey. The third talk is going to be on what did we put in there? Well, that cardiology we're going to save to the end, but we're talking about the physical exam. Since we're practitioners here, and the majority of us employ the physical exam in what we do, how good is the physical exam? Let's take a deep dive into the concept of the complete physical that the patient wants, and how important, how useful is that as a construct. And with my experience in teaching at UConn, the original course in physical diagnosis, and becoming a quote unquote expert in physical exam techniques, I'm going to kind of delve into that a little bit, and I think you're going to be interested in what we have to say as we look at the evidence for the physical exam. And then the latter part of the day will be on sort of a cardiology deep dive, where we'll talk about the most common cardiac arrhythmia, atrial fibrillation. And then we'll talk about, and its management. And then we'll talk about electrocardiograms. And we're going to do I'm going to deconstruct EKGs and then reconstruct it. And depending on time, I have a bazillion cases there, but we'll go through common cases. We'll go through common things. I think you'll find that helpful, the whole construct of how to look at a cardiogram helpful, wherever you are with your skills and interpretation. So it will be helpful to me to have your feedback about how well this helped you as a practitioner. And because I truly haven't never spoken to an audience that's as diverse as this group. We have PAs, APRNs, PharmDs, MDs. It's a very interesting group. So help me in giving reflective feedback at the end. So you will not believe that Andy and I were here last night for 2 hours, because right now this is jury rigged around. This is a jury rigged operation. This is my computer. This is not his computer. And we had it working last night perfectly. So we knew it would work. So we're there. All right. So speaking about errors, so let's go right into that. My conflicts of interest, you're going to find I have no conflicts of interest with any of these presentations, except that I'm going to tell you they're going to expose my own internal conflicts. So what we are not going to talk about, as I said, the stuff that all of our hospitals and our offices are working on, let's make sure we're administering the right medication to the right patient. Let's make sure we're, taking out catheters when we don't need them. Let's avoid pressure ulcers, et cetera, et cetera. We're not going to talk about that, okay? Because we're all trying to do that. But what we are going to talk about, well, before we talk about that, I'm going to practice. Now, this is the interactive part of this. You are all going to be able to be participants in the presentations because I'm using Poll Everywhere software. So with your iPhone on cellular or hospital or rather the hotel internet, what you do is you just go to open one of your browsers, whether it's Google or Chrome or whatever browser, Safari. And in your browser, in the address screen, just put pollev.com. And what will come up is Poll Everywhere software. It'll look like this. Okay. And you're going to join a presentation. So you're going to put in under username, the following username. And you only have to do this once. You do this once, make it work for the rest of the afternoon, rest of the morning, and the early part of the afternoon. You'll be online with me. But you're going to put in my name, Eugene, and the last name, Orientale. That's like Oriental food with an E on the end. Okay, and the number 413. Yes. Or you could just use your cellular. If you turn off your internet and just use your cellular, that'll work. Yeah. The hotels make it very inconvenient in the conference areas to use the internet. Now, when you join, it's going to ask you for a username. Just put in your initials. I'm not tracking any responses. And then you'll join. You'll have to scroll down a little bit and join. And at that point, if you're in, every question will literally show up with all the rejoinders on your phone. Okay? And for the rest of the morning, whenever I raise a question, you just go to your internet, it'll be on there. You don't have to re-enter any of this stuff. So, as a kind of a funny question here, this statement best captures how I feel about medical errors. Everyone in? Anyone having trouble still? Okay, you still can't. Cellular's not. Okay. All right. So a little tongue in cheek here. Yeah, let's make more of them, right? We do learn from our mistakes. We absolutely do, but let's not make them. So, true story. I was given this grand rounds, and it was in February of 2015, and literally the week before this happened. Super Bowl 49. Okay, I don't know if they're Patriots. I'm from the Northeast, so there's a lot of Patriot fans up there. I happen to be a diehard Giant fan, which is not a great place to be, but anyway, they're in it this year. But Malcolm Butler, you remember Russell Wilson? Seattle Mariners are on the 2-yard line. They've got the moose of a fullback ready to run the ball. All they have to do is just cross the goal line, and the game is over, and they've won. They're down by 3 or 4 points, right? Instead, what they choose to do is pass, right? Pass the ball. Now, when you pass the ball on the 2-yard line, 3 things can happen, and 2 of them are very bad, okay? And Malcolm Butler is there, and he intercepts the ball and hands Tom Brady another trophy, right? Now, Tom Brady, he is the GOAT, but this one, he didn't deserve to win. The Mariners lost because of this colossal mistake that was on TV for everyone to see. It was mortifying. I mean, if you were watching this game, it was like your gut was no, that can't, they just threw away the game. It was horrible. And you know what? You make a medical mistake that costs someone dearly, and it is mortifying, right? It's a soul-corroding experience. Medical malpractice, for anyone who has been involved, knows it is a soul-corroding experience. So it behooves us We see mistakes. This one is right in front of us. We know mistakes because we all make them. So what can we do? Let's take a deep dive into what we can do for the mistakes that we make in our heads, either unconsciously or consciously. And so, yeah, okay, we're going to make more of them. But you know, truth be told, we don't remember our successes. We remember our failures more. And that's just a human trait. So the talk today is going to look at the importance of errors, and it's going to specifically focus on how we think. And I'm going to introduce you to some resources that I think maybe later on you might want to be looking at if you're interested in this area. I'm going to discuss some of the more common forms of cognitive errors and these so-called biases. And we're going to talk about remedies for these errors. And the idea here is that, you know, everyone makes mistakes, but if we're more aware of why we're making the mistake or how the mistake was created, that is, we're doing a root cause analysis in our head, we're going to get somewhere so that perhaps we don't make the mistake again. Now, you could say that I was born in the era of medical errors. Truly, truth be told. I'm in medical school, 1983, New York Hospital. In 1984, Libby Zion walks into the emergency room at New York Hospital, Cornell Medical Center. She's 21 years old. She's a, I don't know, sophomore at Bennington College, and she has a painful earache. She comes in with her father, who happens to be a big reporter for the New York Times. She comes in with an earache. The next morning, she's dead. She dies from an arcane drug reaction between Nardil, an MAO inhibitor that we don't use anymore, and Demerol, right? And her father then launches a tirade to change medicine and blames it on the intern and who, you know, didn't have the cognitive skill to know that this medication error would occur. And for all the wrong reasons, a lot of good things happened, but this was the first error. And we were told in the medical school, you don't talk about, if you're asked by anyone, you don't talk about this. You know, it was a code of silence. Okay. Now we bookend my last year of medical school. Andy Warhol comes in, and Andy Warhol comes in for a routine cholecystectomy. Okay. And then of course, the celebrities at New York Hospital get sent to the tower. They go up to the tower, and he goes up to the tower, and he's unmonitored. And the next day, post-operative day 1, he dies from a cardiac complication. Unmonitored, no telemetry. You know, it's just, so we have these two like devastating things happen that really kind of you walk with through your life, and you kind of think, you know, wow, you know, we're living in an area of medical errors. And of course, no sooner, you know, fast forward to the turn of the century here, the Institute of Medicine comes out and writes the report to err is human. Now, when the Institute of Medicine writes a statement, right, we all take notice. And in this report, they say there are something on the order of 50,000 to 100,000 deaths a year due to medical errors. And many of them occur because of systemic issues within the healthcare system. Just to put this, and they kind of help us focus on medical errors, and they provide a useful taxonomy, which really has been used in the last 2 decades to kind of look at errors. But to put this in perspective, anyone been to Buckeye Stadium? No, I haven't. It's the Horseshoe, 100,000 people, okay? That's the number of people, according to the Institute of Medicine, that die unnecessarily due to medication errors or medical errors per year. Put in another context, you take a 737 plane, you crash it every day for 365 days. And that's the number of people, according to this report, that are dying unnecessarily due to errors. So let me give you, before we kind of delve into the cognitive part of this, let me give you some errors that I'm aware of. So, and the physician excuses that were provided. So a 20-year-old Gravida 1, Para 1 delivers uncomplicated spontaneous vaginal delivery. She comes in, she had a trending upward blood pressure prior to discharge, but was attributed to the delivery and some dystocia. 5 days later, she comes into the emergency room seizing. And the physician says, it didn't even cross my mind that she could have had postpartum eclampsia, you know. A second case, a 46-year-old male with a long-standing history of chronic paranoid schizophrenia, who's a chronic chain smoker, develops COPD. and his COPD, and it's, proven by spirometric testing that he has moderate COPD, and he's just getting more and more dyspneic. And the doctor attributes it to worsening of the COPD because he sees him outside just prolifically smoking. He just, one cigarette goes and the next cigarette starts. Fast forward, he presents to the emergency room with shortness of breath, has a chest x-ray which shows disseminated lung cancer in his lungs. And the physician says, I didn't reassess the situation when things didn't quite fit, And then a third case, a 53-year-old, she falls on her stairs and she falls on her sacrum, and x-rays show that she has a compression fracture. And in the x-ray, it says something along the lines, it has kind of a funny appearance to it. But the physician refers the patient to an orthopedist to evaluate the vertebral compression fracture. He says, no, there's nothing to worry about. It's just a compression fracture due to the axial compression loading from the fall. Fast forward 6 months later, a chest x-ray shows she has non-small cell lung cancer. And that compression fracture was not due to the trauma, but it was due to a solitary vertebral metastasis. And the physician says, you know what, I let the consultant, the orthopedist, convince me, even though I saw that there was something suspicious on the x-ray. Now, you might say, who made these mistakes? Well, I did, because these are the things that I said after each of these cases happened, And so the kind of cases that, if you do this long enough, this is not a perfect business. We do not just walk through this and sail through our lives in healthcare without errors. So it behooves us to really think about what we can do personally, professionally, to prevent them. So now I'm going to kind of say, all right, so those are some serious errors. But when we think about our conscious and our unconscious mind, are there traps that we fall into? And what can we do to avoid those traps? That is, are there cognitive pills for cognitive ills? So let's take a little history lesson here. We'll go back to Descartes, who, this dapper fellow, is the Cartesian coordinate system, the father of modern philosophy. But the Cartesian split, when he said, you know what, science and religion must be separate, right? Because all of the thinking at the time was that medicine infused, science was infused with religion. And here, this separation occurred. Well, I'm going to argue that there's a new split in medicine. By the way, if we want to think about the traditional healthcare system that we're in right now, and for better or for worse, this is its birthplace, right? Johns Hopkins. And there you have this iconic building. If you've ever had the Harriet Lane, you'll notice the building, the iconic building on the outside. But in this building, right, you have Sir William Osler, we're going to talk about later, but Sir William Osler appointing Abraham Flexner in the early part of the 1900s to look at medical education because it wasn't scientific enough for him. Okay. In fact, even though we had this split where science was going to be separated from religion, we had medical schools that were producing doctors that would graduate without having ever seen a patient. That was possible. So the Flexner report called for significant reform in health education. And with Osler, they condemned 2/3 of the medical schools in the country, many of which were proprietary. And they said, you know what, we're going to change the idea of how medical education occurs, and we're going to link it to the university structure and university system. And we're going to and the scientific method is going to be the basis for what we do. And hence we had the new system that, and again, I'll talk about this later, but the whole idea of internship, residency, medical education all came from that report, the Flexner report. So, but things haven't changed very much, until now that we have this Institute of Medicine report where, there's been a rapid progression in development of the techniques and science and so on. But the idea that what we bring to medicine in terms of our minds hasn't changed much until we have now this new split represented by the books of Dr. Groupman and Dr. Ofri, where now we're starting to talk about perhaps how we think and how we feel need to really be looked at because they significantly influence how we practice. And now we've entered this new era of bias, and good people are biased. We're all biased. We all project. And so how is it, if we can really delve into how we think and why we think the way we do, now we can start to deconstruct some of our decision making. And so these two books, very, very worth your while in terms of reading. But let me introduce some of the concepts that come out of them. So Brookman, in his book, he talks about the ER as a breeding ground for misdiagnosis. And anyone who receives patients, if you work in inpatient medicine and you receive patients from the ER, you take the provisional diagnosis with a serious helping of salt. Okay. If you don't, you do so at your own peril. Our residents love to it's just a COPD exacerbation. Yeah, and the COPD exacerbation is caused by, it's just a heart failure exacerbation. Yeah, and the heart failure exacerbation is caused by, but the ER, provisional, they got one shot. It's Hamilton. They got one shot, and they're going to do everything they can to make the diagnosis. But there's so much misdiagnosis made. And so we have to really be aware that, geography is often destiny when it comes to diagnosis. I think differently. I'm seeing a patient in the office. I see that same patient in the ER. I think completely differently because I know I have chest x-ray, EKG, blood work, urinalysis. I have everything at my fingertips, CT scan. I see the patient in the office and I think of it in a completely different context. And that's just the nature of the business. So, for example, you've got a 62-year-old presents with abdominal pain, back pain, hematuria, and vomiting. Your provisional diagnosis, right? Anyone would say acute nephrolithiasis. Yeah. And how about missing the dissecting aortic aneurysm? We get locked in. We just recognize pattern recognition. This is what we call medical heuristics. It's called medical profiling. We all do it. And the more you practice, the more you do it. I used to pride myself. I'd say, I could make the diagnosis from across the room. Yeah, you make that diagnosis from across the room at your own peril. Okay, so let's deconstruct that kind of thinking, because that's not going to save you in this case. So the ED, high density, high decision, high stress environment, one-stop shopping, okay? And you get this overly cautious behavior. You get the anecdotal thinking that comes with, I missed that. Oh my God, I missed that dissecting aortic aneurysm. Every patient who presents with these symptoms is now going to get a CT scan, MRI, and et cetera, et cetera. So there's that kind of, unfortunately, that flavors how we work. And you get overly cautious behavior. You get worst case scenario thinking. Pediatrics, for anyone who takes care of kids, knows it's a blessing. There's so much fun when a healthy kid comes in and a family comes in and you're establishing that relationship and you're watching them grow. That's the blessing, right? And kids get well so quick, okay? But when things go bad, they can go bad really poorly. And you can get lulled into monotony and fail to consider more serious diagnoses, and I do this. Again, I'm speaking from my own experience. So medical errors, you also have to look at the patient as a potential source of the error, because patients often are not great historians. They might be, histrionic, if you will, or stoic. There are often cultural barriers. There are language barriers. All of these things contribute to our inability to put the puzzle together. And so we have to consider that as well. And so we all know the pieces of diagnostic decision-making. At the center of this is our patient, but it is the exam, the history, the diagnostic tests, and the way we think. This is not a linear process, but we make provisional diagnoses, we create hypotheses, and then we retest those hypotheses, right? This is what we all do. But I'm going to argue that, and let's just sort of construct the fact that there are overlying Venn diagram here of what you bring to the table in terms of your experience, how you're feeling that day, and where you are as you make these decisions. And all these things play a role in either the correct or incorrect diagnoses. So we're sort of deconstructing now what's just the ether of where we live. Okay. So you see this rash and you see it in the, by the way, what is this called here? That's the love handle. Okay. But you see that that's not the anatomic effect, but you see this rash in the inguinal fold here, right? And everyone's like intertrigo, maybe, if it had satellites, maybe yeast. It could just be irritation from the skin, but probably intertrigo due to fungus. Yeah. Well, how about the fact that if you didn't ask the question, there's also a target lesion. This is actually endemic to Connecticut, Lyme disease. That's your ECM rash, erythema chronica migrans rash. And the idea is that, the history here would have played a significant, if you didn't get the right history, you wouldn't have made the right diagnosis. If you didn't ask the right questions, you would not have made this diagnosis. So we all know medicine is this complex interplay of patient, environment, history, physical exam. So in medical education, we're trying to, it's a profound, compressed period of time where you're trying to take someone who is literally medically illiterate, right, and learn the basics and the terms, put the terms together to integrate thinking and to think diagnostically. And then they get to the third year and fourth year, and we're saying, you know what? We really want you to put all the symptoms together and recognize things as a paradigm or profile. And so we actually teach profiling, and this is called medical heuristics. So we provide shortcuts, and we need to recognize that, in fact, this is a form of profiling. And if we're trying to avoid mistakes, we need to be aware of that. So common heuristics, right? What is the saying here? Right? If it quacks like a duck, right, it's probably a duck. Okay. Yeah. And then we miss the fact that we got a Canadian goose in here, right? The chin strap, that's probably one of the more common birds we're ever going to see. So this is a good example. We see something so often. Yes, that's what it is. But in fact, did we think of something else? Another common heuristic is, if we hear hoofbeats, think of horses and not zebras. But the zebras are horses too. So another common heuristic. So we go to the Gap, and the mission is to buy a pair of pants. Okay. Now one of these depicts the male. This is a very, very, very chauvinistic description here. I recognize that. Okay. But you can see the man has gone to the Gap, and in 6 minutes, he's purchased the pants for $33. His cohort, okay, on the other hand, has gone to all the marquee stores before getting to the Gap, and in the process has spent, considerably more money, okay, in doing so. But again, this is profiling. This is an example of profiling. We all kind of think this way. So, and then we're going to look at, this common theme in medicine. We like to just keep things moving, and the way we keep things moving is when there are multiple competing hypotheses, we choose the simplest one to explain what we see. And that is that fallacy sometimes of Occam's razor. We just go right to the chase. This is what it is, So let's kind of deconstruct some of this. One more thing, and then we'll kind of look at some common biases that we all employ in our work. Sutton's Law. Sutton's Law is named after the famous bank robber, Willie Sutton. Right, Willie Sutton, he was incredibly successful at robbing banks. And he amassed a huge fortune before he was finally caught. And when he was finally caught, he was asked why he robbed banks. Remember what he said? Yeah, because that's where the money is, right? So that's what we do. This is the way we think in medicine, So Sutton's Law applies. So what I want you to get you thinking about, I guess, a little bit with this talk is the fact that how you feel affects how you think, and how you think affects how you feel. And so the domains of cognitive error often occur in this domain where we're not quite in touch with what we're feeling. And so the idea that we can parse out, I think I'm going to give you the summary here. We need to all practice as if we have infinite amount of time. That's really what we have to practice, as if time does not matter. And yet none of us practice that way, right? But that's really the asymptote. That's really the goal. So how do we get there? I will share with you, when I am tired, when I am hungry, when I am angry, okay, I think differently. There's definitely truth to the hangry hypothesis in my house. Okay. The environment that I work in, am I working with a group of providers that are working together? All of these things affect how I approach my work. I think the idea of curiosity and bringing into the equation, hey, I'm going to be thinking about how I'm doing today before I even step into my work, is something that Bernie Siegel champions, the famous author. So as we look at these biases and these cognitive dispositions to respond, or biases, there's many, many listed in the literature. And in this talk, I just want to give you a few that I think you're going to see will touch home. And I want to make you aware of them with the idea that maybe, we all can't eliminate our biases. You just can't. But if you're aware of them, then maybe you can change how you behave. Okay, and I guess that's really the hypothesis here. So the biases that we're going to look at, I chose 6 that I think are sort of my top 6. So I'm going to take the liberty of sharing them with you. Outcome bias, diagnostic momentum, availability and non-availability, zebra retreat, fundamental attribution error, and premature closure. So let's take a look at them. And you guys are going to participate now as I give you the bias, and you're going to tell me which one it is. Okay, so we'll start with the easy one. The tendency to settle on a firm diagnosis before completing the medical evaluation. Something none of you do in this room. We're seeing how people influence each other, because you can change once you see someone else's response, you can change yours. Okay. But we're going to call this, when we're settling on diagnosis before it even occurs, that we're going to call that premature closure, right? We've already decided, and we haven't got everything together. We haven't obtained all the history that we need. We haven't perhaps obtained the appropriate diagnostic tests or done the parts of the physical exam that are relevant. And unfortunately, once you make the diagnosis, the thinking stops. Yeah, we stop thinking. We just kind of get stuck. And this becomes a real problem, because this is the way we miss things. And so what I'm going to suggest is, since we all do this, you have to first be aware of the fact that it exists. And probably the most helpful thing I can tell you is to do this. If you feel yourself coming to that diagnosis and you just can't get out of it, ask yourself, all right, that's my provisional diagnosis. What else could this be? So this way, when the COPD exacerbation comes in, and yes, it's another flare of the patient's COPD, they've had 3 of them in the last 6 months, stop and ask the question, all right, first of all, it's syndromic thinking. What caused the syndrome to occur? But also, what else could this be? And so you don't miss the PE. You don't miss the MI. You don't miss the dissecting thoracic aneurysm, okay? So sort of, again, you're stuck, my provisional diagnosis. What else could this be? And that's the way you engage your mind again in thinking. So that's a really helpful way. And it's really it's the AKA the differential diagnosis, right? So consider all the data and don't stop thinking. All right, second bias. Tendency of diagnosis to stay with the patient, regardless of its accuracy. Okay, we're going to go with the majority here. We're going to call this diagnostic momentum. This is what comes out of the emergency room, right? Patient gets labeled, whether it's accurate or not, and especially now with electronic health records. How many of us are guilty of not updating our problem lists? And we think provisional diagnoses, rule out diagnoses, and they just stick. And then we're looking and you go back, does this patient have heart failure? Patient never had heart failure. It was just a rule out heart failure diagnosis. And yet there it is stuck on the problem list. So diagnostic momentum is a common bias that we have. And it really is a problem for particularly those of us who are primary care, work in primary care, where, there might be a provisional diagnosis made, and without an updating of the electronic health record by the specialty or the ER provider, all of a sudden a diagnosis is there. And what are we asked to do? Review problem lists, review medications, review orders, right? So we press those buttons. If we're not, we should be looking as we press the button. Okay. Not just the credit. Right. So but if you look at the problem list, sometimes you see things that absolutely make no sense. But more importantly, we see a specialist come in and say, oh yeah, this is sclerosing cholangitis. There's no question about it. And everyone goes, oh wow, we have a case of sclerosing cholangitis. And then the medical student comes along and goes, but isn't there a triad of symptoms that's supposed to be it that we're not seeing? And all of a sudden we deconstruct, everyone, assumes that the diagnosis was the correct one. And so take care, make sure your diagnoses are correct, update your problem list. Okay, so always rethink diagnoses, differential, and this is the dictum, trust but verify, right? Trust but verify. So you're going to look at the data yourself. It's no longer a good enough excuse in medical malpractice circles to say, well, someone else ordered the test. I'm not responsible for the result. As a primary care physician, all the results are a part of our purview. We're supposed to review everything that comes into a patient's chart. And we're supposed to ask questions if we see things that are out of line, that make no sense. We ignore data at our own peril, right? So we really have to be looking at all of the tests. And this is why one of the things I really try to master with the residents that I work with and faculty is try to master looking at primary data yourself. And that's why EKGs, we're going to do a lot of, I know I can read an EKG with my eyes closed. It's not rocket science, but it's a skill you learn. I can look at chest x-rays and get a reasonably good interpretation myself without waiting for the radiologist to give me the read. And so if we can build our skills with primary data, I think we really do ourselves a service in making better diagnoses for our patient, because we're responsible for the data. Okay, another bias. This one, tendency to think of a diagnosis, it's likely if it readily comes to mind. Yep, and everyone got this correct. And you know what? This is a function of the limitations of the human mind, right? We can't make the diagnosis of Takotsubo's cardiomyopathy if we've never heard of it or never seen it. This is the greatest argument for broadening and widening clinical exposure to whatever extent that's possible in your training. And availability is a function of knowledge, right? But for those who walk around with an almighty sense of themselves, and there are many people who do that in the hallowed halls of medicine, okay? There is so much that we don't know, and the idea is we need to know what we know what we don't know, and know when we need to ask for help and assistance, right? That's the name of the game, wherever we are in the spectrum of healthcare. And we also have to know that where we are can affect how we think, right? We said that earlier. But let me take you into something this is such a fascinating parsing out of knowledge. And I think it'll be helpful for you too. I'll never forget this talk. This is early in my career at a Society of Teachers Family Medicine annual conference. And these two physicians spoke from the University of New Mexico School of Medicine. One of them, I forget which was which, but one of them was the foremost lymphologist in the world. The other one was the foremost vascular surgeon in the whole region of the southwestern part of the country. Okay. And they developed at New Mexico this school called the curriculum on medical ignorance. I thought these two most, esteemed people, right? They're developing a thing on knowledge and what they did is they said, you know what, there are actually 4 domains of knowledge. Okay. And we can describe them based on what we know and what is unknown. Okay. So they say the domains are the known, the known unknown, the unknown known, and the unknown unknown. So what are we saying here? I know something that is known. Okay. This is where we all want to live. This is evidence-based medicine. This is good stuff. This is where we want to work. This is where we want to operate. Okay. This is being intellectually honest. I don't know it, but it's known and I can look it up. And I can look up the GDMT management of HFrEF, and make sure I'm titrating my Entresto to the right dose. Okay. I don't remember what that dose is, but I can look it up. Okay. So this is where we live. Okay. The humble physician and the humble provider knows that there is so much that we don't know. And these docs, as esteemed as they are, they don't know a lot of stuff, and if the human mind, the final frontier, right? We don't even understand how a thought is generated. Right? We don't know how it happens. We understand the neuroanatomy. We have an understanding of maybe 5 neurotransmitters. We understand the dendritic and synaptic connections, and yet we can't even begin to understand how a single thought or memory is stored, right, or created. So there's so much we don't know. And then this is the world of the so-called bullshitter. Okay. Oh yeah, I know it. No, you don't know it. You don't know it. And and we see a lot of this in medicine. People do this because it's a feign, it's a defense mechanism against not knowing something. And sometimes you're just lying because it is known and you don't know it, but sometimes it really isn't known. And this is a scary place to be. And so I thought this is really helpful. And it's a humbling statement to the domains of knowledge. So no matter how much experience, if you have 1,000 hours versus 7,000 hours of experience, the reality is even the most esteemed clinician doesn't know and hasn't experienced everything there is to know. So recognizing this really helps us, I think, kind of sit better with availability and non-availability. But the truth is, we can't know something if we've never known it or know about it. And so I guess this is the big argument for good clinical training. Okay. And the intellectual stigma associated with the medical student differential diagnosis, for those of us who work in medical education. Right. And this is the so-called zebra, right? And we've all been there when the medical student, and some of you probably have students working with you in your offices. And we all know students come up with the most esoteric, interesting, and often irrelevant diagnoses, right? But sometimes you scratch your head and go, oh my God, you're right. I didn't even think of that, right? And the idea that we retreat from this, and we do often, like the residents, when you're in the hierarchy of the teaching circle, you see the residents laugh at the students who are generating different, obtuse differential diagnoses, when in fact, some of the things they're thinking are probably not that far, that should be thought about. Everyone is so locked into the diagnosis that we're not thinking like the student, who really is bringing a child's mind to the work. And so, we want to honor the thoughtful differential diagnosis. And there's always and we can weigh probability and possibility, and we can do that, and we can do that in a genteel way. I always say my favorite consultant is the one that knows how to consult and not insult, right? And that's the way we should be in our educational service. That's the way we should be with our providers. That should be the way we are with our patients. So how do we consult and not insult? And so we can do that. And with the student, we can certainly do that and weigh what they're saying as, that is an interesting and thoughtful, but not necessarily, likely. But we're also going to remember zebras are animals too. Okay, so sometimes the zebra and the preposterous, what seemed like a preposterous diagnosis is actually the right diagnosis. And so this is a bias that we have. Like the bias is, it's like electric. We hear the obtuse, this is Takotsubo's cardiomyopathy. And you just go, no, that's not Takotsubo's cardiomyopathy. And the electric shock of not even entertaining the diagnosis keeps us from kind of entertaining a more broad differential diagnosis. Okay. And now we're getting into the intrinsic and extrinsic biases here. And this one's the tendency to blame the patient for the diagnosis. Right. And we're going to call this fundamental attribution error. And all of us are guilty of this. Whether we think we're the, quote, most unbiased person that ever existed, okay, which is a testament to the fact that that is untrue if you ever make a statement like that. But the idea that we look at people and we make judgments. And those can, and I'm not saying you do that from a negative place. Sometimes we do that from, oh my God, this looks like my grandmother. I want to take better care of her. She's my grandmother. You know, this is a very attractive person. Oh my gosh, you know, your reaction to that. Or just the opposite. This person is so disheveled and doesn't care for themselves. Why should I care for them? You know, the idea that we might actually, how people appear might actually influence how we behave. This occurs, whether we admit to it or not. And we just need to be aware of it so that we don't label patients like, oh, this is the alcoholic. This is the drug seeker. You know, when I hear the residents say that, you know, no. This is a patient who suffers from alcoholism, you know. So don't just label the patient. They're not the disease. They are a person first, right? And they have disease. So you know, we see this all the time, and we just need to be aware of it. And it does, you know, it affects how we behave and how we act. And now there's a lot of data to say that, you know, race has a lot to do with how we behave, and sometimes whether we do something, an intervention or not. And in cardiology, that seems to be really being studied with great acuity. So fundamental attribution error, you know, you have to recognize that you react to patients consciously, but you also react subconsciously to patients. And one of the ways that physicians can get around this is by actually talking about it. And that's where physician balance groups, if you have this kind of support group in your community or your state, a society has this with nurse practitioners or physician assistants, you know, you want to consider doing that, because the more you recognize and the more you can talk about stuff, I think the more helpful it is to affect and impact your thinking the next time you behave in a way that you find is sort of untoward to the patient. And I guess a cognitive pill for this is to, if you're having a negative reaction, you know, I know sometimes, you know, I take care of a lot of elders, and unfortunately urine has a very, you know, when people can't take care of themselves, you know, how teeth appear, how feet appear, how odor appears, all those things tell you about ADLs and IADLs. And sometimes, you know, it can really affect, you know, you want to stand back, you know, and I'm not saying you jump in someone's, but you know, the idea is that be aware of these things. And, and the reality is, if you could change your perception and say, you know what, I'm going to endear myself to this person who I'm having a very negative reaction to, you know, I'm going to try to understand them first, you know, and I'm going to try to visualize them as a friend or relative, and make sure it's a relative you like. Okay. And of course, we're in this business to value everyone and every person as a human being. And that's what we do. And that's really the goal in understanding this bias. All right. The tendency to make a diagnosis based upon your relationship. This is kind of a play on that one, or with or toward feelings toward a patient. Actually, I think we just did this. Oh, no, we didn't. I sorry. Okay, thank you. That's the right diagnosis. This is called outcome bias. So now this is a little bit of a play on how we think and feel based on what we see. Now we're going to say, you know, how we think and how we see is going to affect how we think the outcome is going to occur. Okay. So, oh God, this patient with they're a train wreck with their diabetes. I can see it coming. Limbs, renal failure, heart disease, and you project this whole untoward outcome scenario because you've already judged the patient, as opposed to, oh, this is my boss's child, and I'm going to care for them much with much more acuity because I want to make and this can't possibly be. And all of a sudden, the way you're thinking, the positivity you bring to things changes how you think the outcome trajectory is going to go. And so the idea, again, we're getting back to Ofri and Jerome Groopman's books here. How we think and how we feel affect how we project outcomes. And being aware of this, I think, is one of the ways to overcome it. So it is the law of attraction. Anyone see that that silly thing on YouTube? It's like a 1-hour documentary called The Secret. It's kind of entertaining. You might want to watch it, but it's basically the whole idea that there was, Thomas Jefferson and George Washington knew it, and Benjamin Franklin knew it. What did they know? They knew the law of attraction, which was that's the story in the Secret. It's basically, you think, you feel, you manifest. The idea that you can actually project an outcome based on what you're thinking and feeling. Now, I've tried this when I'm parking a car in a garage. I say, I know there's a spot available. I know it's close. And damn, if I keep driving around, there's no spot. And it doesn't work. Okay, that's just a small example. But the idea is we think we can make things happen with our minds. And unfortunately, this is a bias in medicine as well. So be aware of it. It is going to be what it is going to be. Sometimes we have no role in the outcome. Going in the wrong direction. Okay. So, and then, here's a note. We all want people to listen to us because we know better, right? And so we tend to, and patients who are recalcitrant and don't take our advice, and we've had an awful lot of that in the last couple of years, right? We tend to dislike them. And you have to really tone that down, And I'll tell you, I was at my wit's end when I had a family less than 12 months ago tell me that they were going to sue me and the hospital and our department if I did administer ivermectin to their family member. And then to go further, and I'm just listening, and they go, and doctor, you need to read more. You need to read more about ivermectin. So I was at my wit's end. I'm trying to really work all these, but I just, sometimes people take you to your limit, and you have to kind of, so how do you turn that around? How do you sublimate that? How do you make it happen so that you really remember everyone is a human being, and people make bad decisions, and you just have to kind of keep that in mind, and you can't let your hope for a positive outcome encroach on your ability to objectively figure out what's going on. So just to kind of summarize, heuristics can fail us, right? If it quacks like a duck, it is a duck. That's the old availability era, right? Because I don't know that the geese exists, but it could also be a geese, If it's hoofbeats, I'm thinking horses. Well, yeah, but I'm running from the fact that zebras are out there, and they do exist. Occam's razor, it's what everyone's going with. Everyone believes this is the diagnosis. This is what it is. Well, yeah, how do I unlock that diagnostic momentum and availability bias? And then Sutton's law, this drives us to the premature closure. The money's there. This is where it is. This is what it is, a diabetic foot ulcer. Well, what about the foreign body that's in the diabetic foot ulcer that you didn't get the X-ray on, So you just keep in mind that these are common, these things really help us. They help us move through our day, but they also can delude us. So strategies is kind of a summary here. Strategies for preventing cognitive errors: get good training, right? And work with people who are going to teach you and you're going to learn from, and do things like this ongoing CME, right? With university learning systems. Well, you know, develop a collegial ethos, behavior system with your colleagues. You know, I have colleagues in every field. I've got them on speed dial. You know, I have friends in medical school. I'll call my medical school roommate. Feel like you can get help. You're not alone. You know, seek advice and second opinions. We have to do that. That's the world we live in primary care. Remember, there are rational reasons for clinical decision support now in our electronic health records. You know, I don't know, those of you who's Epic in cost, Epic in pain. I'm not Epic in value, but you know, there are some things in it that, you know, really do drive cost savings. And then the idea that, you know, when we're transitioning our care, we're leaving for the weekend, we sign out patients, we're leaving the hospital service, we sign out, we make sure we transition, and we address those things as we kind of move through, so people don't fall into the traps that they easily can. You know, we all have these ways of seeking feedback through audits and morbidity, mortality reviews. It's a real challenge in education to bring bad outcomes to a learning circle and to do it in a way that's not destructive to the psyches of the people who are involved. And it's a real art form to be able to do this well, you know. I challenge you to read Sanjay Gupta's book, Monday Mornings. It's incredible. Sanjay Gupta is a pretty neat guy, and you read his book and you'll be even more impressed with him. He's a neurosurgeon trained at Hopkins, and he talks about Monday morning morbidity, mortality, where they would ream each other over the coals for mistakes that were made. And it was like, you didn't want to be in that seat, in the hot seat, because you were, and that's a destructive psyche of medicine, right? We're moving away from that. But in this book, he talks about it really quite poignantly. And the idea we do root cause analyses, you know, in what do they call that in the military, AARs, you know, sentinel event analyses. The idea that we're going to take the energy to go back and look in a non-judgmental way and to see what could be done differently. You know, this is the whole idea of the Swiss cheese model. You know, if we can not make the holes align, we can reduce the frequency of medical errors. And all I'm saying, I'm introducing a whole nother hole for you. This is the one that's in your head, right? Today, this is all stuff that we do that we don't even think about. How we think, how we feel. We just do it. And then the idea that we're going to perform a cognitive and affective autopsy on errors, you know, so that we can also incorporate this into decision making. This is not a big strength of medical education. So for us as providers, you know, we have to move through our grief. You know, I mean, everyone knows this. You know, you say it straight or you show it sideways. And we have a lot of patients who show it sideways. We can learn from our patients. Our patients are our greatest teachers. So how do we navigate our feelings so they don't destroy us, but rather serve the larger goals? Because we're in this business to stay. We're not in this to go until we make a mistake and then to run, right? We're in this business to stay and to work through our mistakes and learn from them and become better people and better providers as a result. And there's that saying, you know, if we fail to go within, we go without. You know, and I'm a big fan of coaching. You know, you don't have to call it therapy. You have to call it psychoanalysis. I call it coaching. And I have no hesitation to do it for myself, to do it for our medical students who are in trouble, you know, our residents when they are suffering. You know, this is the compassionate thing to do. You know, so I think there's always a time for this, because you know, now I've been in medicine long enough to see a lot of my colleagues, and for those who have transformed and have grown, you know, they thrive. And then there's so many that just burn out and don't thrive, you know, and their lives are a mess and they're not caring for themselves. And we'll get into this in the next talk. It's kind of a segue into the next talk. So I really think I'm a big fan of, you know, and I tell people, you go for the counseling, make it it's a 10-pack. There's a start, there's an end. I'm going with I want to work on this. That's how I frame it for people. You want to work on something? Let's go. You know what? I know a really good therapist. And by the way, psychiatrist doesn't stand at the highest point of that hierarchical circle. Forgive me if there's any psychiatrists in the room. Okay. Because they're pharmacists. They're prescribing, and they're not spending the time that a therapist, an APRN, a master of divinity, people who really understand human behavior, social workers, MSWs, better therapists than some of the psychiatrists of the highest fame and credential. So the idea that people can do targeted coaching to help them, and the problem now is how you pay for it, right? Because anyone who's good at this doesn't take insurance, and so that's always a big hurdle for patients. But anyway, I just want to kind of leave you with that. And then a couple things that came out right as the time I was putting this together. This was in an editorial from the editor of the Journal of Family Practice. It was apropos because it was the time I was putting this together. And he wrote an editorial and he said, the way I get around errors, or the way I try to, is I listen carefully. I try to find out what, we talk about the 7 parameters of a symptom. What is it? Where is it? What does it radiate to? How bad is it? What makes it worse? What? Yeah. And what's the 8th parameter? I asked the student, what's the 8th parameter of symptom? What do you think it is? Okay. What do you think it is? What a beautiful question. Does so many things. First of all, it tells you about patients' health literacy, but it tells you what they fear. It also tells you if they're way off the mark, but it acknowledges and it affirms that you actually care about what they feel to start with. So what a powerful, and for a medical student, I say, and half the time they're going to give you the diagnosis. So ask them, don't play puzzle. It doesn't have to be a puzzle if they can tell you, oh yeah, I have COPD. That's the cause of my shortness of breath. So the idea is asking about the dreaded diagnosis often will help us, and it helps situate for the patient who fears cancer. And so many patients walk around with that fear. You can tell them where it stands in the differential. Now you've acknowledged that they are fearful of that. And you wouldn't have known that otherwise if you didn't ask the question. Don't skip the physical exam. Well, we're going to hold this to the third talk to maybe skip the physical exam. Okay. But don't skip it because it's part of the exam, part of it. You're going to follow up. Beauty of what we do in primary care is this isn't one shot. You got many shots. You don't have to make the diagnosis the first time. There's the law of attrition. People wear you down. There's the law of the tincture of time. Tincture of time? Take a little time and you put it in a bottle. Oh, and everything gets better. You didn't do anything. You just waited there. So tincture of time. And of course, reconsidering. Things aren't going as you're expecting. That's when you start to change your diagnostic. And a beautiful little summary there. Now it's 33 years. It was a quarter century when I put this together. Okay, so what do I have to say? All right, prepare yourself for the work. It's serious business. You can't go in like, I'm going to have a shitty day. I'm really tired, and you know what? I really don't want to be here. No. Change that, right? You're into work. This is your job. You're going to do. Prepare yourself for the seriousness. Especially, I teach technical procedures in the office. I am such a, and I'm pretty good. I've done it for a long time. But I always tell the resident, always prepare for the worst possible outcome. I know this is just an Explanton removal. But you know what? Sometimes it turns into a 30-minute procedure and there's blood everywhere, and you thought you were just going to make a little incision. The idea that you got to prepare yourself. Be prepared. It's a Boy Scout motto. Be prepared. Okay. Again, the ethos here, the talk, keep an open mind, be aware of your biases, rethink your diagnosis. I love that. This is my provisional diagnosis. What else could it be? And the last thing I'm going to say, I'll just tell you a quick story. So when I was trying to decide what to do in my career, I was working for IBM during the summers in college, and I was given an opportunity to go to the Watson Research Center. And I went to Watson Research Center, where they have literally Nobel laureates. And IBM has patent upon patent because of who they have working behind the scenes for their work. And I sat with one of my neighbors who was this brilliant scientist, and I asked him what he did. And he goes, well, I think. I go, well, what do you think about? He goes, well, and he shows me his lab. He goes, all these people think with me. and we spend the day thinking about problems. And I kept parsing, what do you think about? He goes, well, I spend the day thinking, and every quarter I report what I've thought about to my boss. I go, wow, I want that job. I go, I really want that job. You know what? I have that job. Okay, I have that job. And when I get lazy, I have to remind myself, I'm paid to think. That's what I do. When you get lazy and you say, you know, I don't want to, my head hurts, you're paid to think. That's what we do, you know? And so I remind myself, that's probably, that's where the money is for me. You know, remind myself why I'm doing what I'm doing and why I'm being compensated so well for what I do. Okay. So I'm going to open the discussion at the moment. I think we have plenty of time. To the audience, if there have been any questions on the chat side of things. Charlene, is there any, I don't see any chat questions. Okay. Any questions from the audience or? Not well. Not well. But you know what helped me? You know what held me together was the residents, because I knew if I just got into it with them and there was a team of residents with me, I thought this is going to look really bad. I better model some really good behavior. And I said, we're just not going to do that. I said, I'm sorry, we can transfer your loved one to another hospital if you'd like, but I don't recommend that given the severity of their condition. And so I gave them an option. You know, it's like treating a toddler. Well, you can have this, you can have that, but you can't have what you want, you know? So, but I was really angry. I was so hurt. You know, I think I was personally hurt, you know, and it's degrading and it was so stupid and I was so angry. You know, I don't want to go into COVID, but the unnecessary suffering of so many people because of how we dealt with it as a country. You know, this was a giant science experiment. People don't understand that. It was a giant science experiment, you know, and there were miracles that occurred along the way, like the development of the vaccines, a freaking miracle, you know. And that mRNA technique, as we learn more about it, it's going to be the way of the future for vaccines. We're going to be able to typecast exactly what we need and cut it out of people because we have this technology. And to pervert that into, you're going to change my DNA, you know, it's just, you know, really. So all of that baggage was with me as I'm talking to this person, and my anger and the people who the people who I held the hand of dying people, you know, with this disease. And here I am being told that I need to know, you know, I just, oh, wow, it was so powerfully painful. And yeah, so I modeled good behavior, but then I took it home to my wife. Okay. She said, you know, she reminds me, I told her, by the way, she's a teacher of the deaf, and she's been teaching for 30 plus years. And I told her, hon, I'm going to lecture for 5 hours this morning. She goes, so what? I do that every day. You know, I'm like, oh yeah, I forgot. Okay. Anyway, yeah. So thank you for the question. Yeah. Bringing all of our own